Hello.
I'm here, Chad.
It's like, come all by myself.
Talk to me again. I couldn't hear you.
Oh, can you hear me now?
Now I can hear you. Okay.
Oh, okay, good. Like, I don't want to hear myself either, but I'm trying to.
Hi, LJ.
Hey there.
Hello. Hello, Nick. From down the street. Everybody, one more minute.
Bueno, el Pepsi. Where's the Pepsi? On it, Pepsi.
Is that to me?
Hey, folks, please remember to put yourself on mute. Thank you.
All right, why don't we get started? We're having way too much fun. We haven't gotten started yet. So welcome back, everybody, on a very dreary and rainy September day. So quite a few things to go through. Hopefully not a terribly long agenda, but hopefully should have plenty of time for questions. I know many folks have been reaching out on a myriad of issues. I'm going to try to touch on those as best as humanly possible, but if I forget something, don't hesitate to remind me, and I will try to speak to it. So first and foremost, we have a slide that Nick Apostolaris and his team put together from down at Tri-County, which shows the kind of regional incidents. May is pulling it up as we speak. I see her doing it.
Sorry, letting people in as well. So
Oh, all right.
I'm bringing it up. Keep talking.
Yep. So we are seeing, I think pretty much the entire region is either in the very high or now extremely high category of new case rate. Of the southern counties where we have less vaccination, the center of Rochester are all kind of in that more significant elevation. Obviously, there is a big concern of what the Labor Day holiday may bring. Lots of folks were vacationing. There were lots of social events and parades and the like, with a lot of unmasked folks crowded around in small areas. So there's a significant concern that we will see a ripple effect come from that. As of yet, we are still, as you'll see, although we are still trending in an upward direction as far as hospitalization rates, we are still lower than where we were in the earlier part of the year when hospitals were overflowing around the Christmas, New Year's holiday time period. There you go. So you can see this here. Pretty much every county is on an upward trajectory. Southern region counties certainly maybe a little bit more represented, although if you look by zip code, you clearly see there are kind of some hotspot kind of areas that are emerging. There have been some isolated pockets in congregate living settings, some group homes that have had some outbreaks, even where there is relatively high degrees of vaccination. Thankfully, most of those cases have been relatively mild. But because of discomfort or uncertainty in these congregate care settings, they have been sending patients to the hospitals. I would say maybe not as frequently as they were before, but we have seen some, exodus from some of these smaller facilities where there may be 5 to 8 folks living in one of these settings who get, half of them get sent to the hospital in one day, and then the next couple trickle in over the next couple days. So we are starting to see a little bit of that. But on the whole, it just seems to be kind of regional transmission. Even as bad as things are, we're not as bad as we were over the change over the year, but we're certainly not as bad as some of the other states. So it definitely, although there is, it's predominantly an unvaccinated group, even in the Northeast and California. If you look at the states where vaccination rates are 45% or less, that is where you're seeing the highest preponderance of new infections. Many of you have probably heard there are now Facebook pages where folks physicians are actively going on. I saw one yesterday in Texas where they were looking to transfer a ventilated patient, and it was around Plano, Texas. There were no ICU beds within 90 miles of Plano, Texas. And so they were reaching out over social media contacts, looking for anybody who had bed space that would be willing to accept those patients. We are starting to see in smaller pockets here locally that we are starting to see some transfers of ICU patients, even going south across state lines into Pennsylvania because of lack of availability. So some of that in the Northeast is more due to staffing issues, whereas in the South, kind of Southwest, it's more related to pandemic spread to some extent. So we're kind of battling two things at once simultaneously. But for now, testing remains readily available. I know several folks have reached out asking questions about getting testing in the offices. I would still contend, while there may be inherent value if you can make a justification for that system long-term in your office for the other tests that it can run. There is still a fairly significant reagent shortage for both Roche and Cepheid at this point. So even if you can get a machine, getting the reagent is still somewhat difficult, which makes it a questionable proposition, I think, at this moment still. Fortunately, the PCR test availability remains quite available. Turnaround time remains very rapid. So I don't think we're in the same boat we were before when we were seeing cases rise and testing availability kind of flat or strained. We seem to be in a pretty good space as far as testing. So several folks have asked, is now the time to get a Cepheid or Roche? I would say, based on reagent availability, my answer would be no, unless you have a real good justification that you are looking for a lab system for your office anyway, in which case I would say, okay, makes sense to probably get one that can do COVID, but just don't count on being able to get the reagent kits in the short term. So that's that piece. Briefly, I want to cover the booster discussion because several folks have reached out. It sounds like some folks are maybe going a bit above and beyond up to the edge of what would be considered immunocompromised state. And folks have reached out to say, is this kosher? Is there something we should be doing? Other than trying to provide the education, most of the pharmacies and state pod sites that are offering booster doses to immunocompromised individuals, as long as the patient is willing to sign the statement that they are attesting to having some immunocompromised state, they are not asking for any proof. They are not putting them through any grand inquisition. So largely, I would say, right or wrong, you can pretty much get access to a booster dose at this minute if you're willing to sign the attestation. So I don't think there's any reason that anybody needs to go to any extreme. Folks have reached out, should they be calling pharmacies to say this person should be put on the do not allow list? My guess is you're probably going to create more issues for yourself than it's probably worth, but that's just my own 2 cents at the moment. As far as third dose boosters for the general public, we talked about this before. September 20th is the date that it is anticipated that these will begin to be available for those who are 8 months status post the second dose of their vaccine. There is still quite a bit of ongoing discussion at a federal level where the CDC has actually asked the Biden administration to slow down recommendations for boosters. There is some question or concern as to whether waning antibody immunity truly reflects waning immunity. And some more recent studies that have come out in the last week or so suggest that that the waning immunity may not actually be reflected in public health data. And in fact, for anyone who reads the Buffalo News, there was a really good article this morning which showed that across the board in vaccinated individuals, the chance of developing COVID at this moment is about 1 in 5,000. If you look at areas of relatively high vaccination, of which the Northeast and California are most often cited, that risk drops to about 1 in 10,000, even with levels of transmission being where they are. So that both confirms that the vaccine still seems to be having a pretty high level of success, even this far out, but also that this surge that we are seeing is largely a surge of the unvaccinated. It is absolutely true that in the hospitals, we do have vaccinated individuals who are getting admitted and even getting admitted to the ICU and being put on ventilators. But that is a minority for sure. And they both seem to turn around faster and recover more swiftly than those who are unvaccinated. I can say that just from my own experience. So for right now, the boosters, we're still a couple weeks away from that even being a reality. The anticipation is, I know the U of R is going to begin offering booster clinics on or around September 20th. Obviously, folks who got vaccinated in, say, March, April will not be due for a while yet. So it's really only going to be that first wave of healthcare employees who got vaccinated, in the middle to end of December, who really will even be in the discussion for getting vaccinated at these first few booster dose clinics. And I don't think it's one of those situations where it's a clear and convincing evidence that it's necessary at this moment. So that's my 2 cents on the boosters for right now. The next point I wanted to raise, well, I had my list here and I've quickly forgotten. So a couple folks have reached out with healthcare workers needing to potentially meet the September 27th mandate. For folks who have recently contracted COVID, but are now willing to get vaccinated to meet the mandate, what is the timeline from date of resolution before they can get the vaccine? Remember in the beginning, we were saying it's 3 months from the time that you had COVID before you were vaccine eligible because the immunity from the virus carried you. And I answered someone this morning and said 14 days. Renee subsequently sent me the information that reminded me that I was incorrect. It is actually 10 days post resolution of symptoms or asymptomatic, 10 days post positive viral test that you qualify to be vaccinated. So 10 days after symptoms began, 24 hours fever-free, and symptoms improving is the requirement for when you can get vaccinated. I believe, although I do not have it on strong accord, that the general recommendation is, let's say someone were to get infected with COVID today, and therefore, they would have, let's say, a week of symptoms, and they may not meet that 10 days free before the 26th to get vaccinated. Would they have to be terminated at midnight on the 26th because of that? I suspect that there's going to be some allowance for putting folks on leave for that period of time, understanding that they get vaccinated, on or about that 10-day window post resolution of their COVID symptoms. So I do think there's going to be a little bit of wishy-washy about that, but a couple folks have reached out about that, so I just wanted to make sure I addressed it. The next piece that several folks have asked about is Regeneron. So administering monoclonal antibodies, is it available in Rochester? Can I do it in my office? If so, how do I refer my patient or go about it? So it is available in Rochester in limited availability because it is currently being administered in infusion clinics, and those chair spaces are limited. There is now the ability to administer it sub-Q. And there is a process by which you can go about applying to get drug to administer in your office, is my understanding now. It's a little bit circuitous. I know a couple have reached out, at least one, I think, is already going through that process. A couple more have reached out just in the last 24 hours asking how to get access to it. I would say it's a bit limited to refer a patient into it at this moment. In fact, I couldn't tell you how to go about that right now. But if you were looking to be able to administer it in your office, I think the big holdup is not only you have to give the sub-Q or IV infusion, but then you have to monitor the patient for an hour afterwards. And so there's some logistical piece to it that makes these patients tie up an infusion chair or an exam room, whatever, for a period of time. So yes, it is available. No, it is not widely available at this moment that you could just refer patients in. Several folks have reached out and said, is this now the standard of care? And we're kind of missing the boat by not referring patients. I would certainly not say it's reached the standard of care level at this moment, but it is becoming more generally available at this point. And there is, my understanding, there is a newer drug that is available in kind of emergency use authorization at this moment, but which is administered by a tablet form. I don't have a lot of details about that one, but it sounds like that may be coming more readily to market in the near term. And if so, that may be a alternative to competitor for Regeneron, but certainly I don't have a lot of data about that one yet. So I will make sure I'll give that link. Kurt Haas from pharmacy provided some information about the Regeneron certification process to be able to administer it through your office if people are interested. We can put that out in the email that goes out today if folks wish to pursue that. I think that largely covers the updates of what folks have reached out to me for. I will touch briefly on the vaccine mandate, just because several folks have asked, what does this mean for hospital capacity? What does this mean about nursing homes? What does this mean about my employees who may work in a hospital setting? So as of right this moment, and I will say that this may not be true in 3 hours, but right this moment, everybody, please, thank you. Right this moment, the state and Department of Health are standing by that the mandate is an absolute requirement, that they are now allowing for religious and medical exemption. However, the only clear-cut medical exemption is for those who either have had anaphylactic reaction to the COVID-19 vaccine or have anaphylactic reaction to any of its parts. And I will tell you, there's already discussion in those cases of allergy and immunology doing desensitization to get those folks vaccinated as well. So very narrow medical exemption. Religious exemption was there, then it was gone. Now it is back because the federal government, from what I understand, said, no, you can't wipe away the federal religious exemption allowance. So now the state has put into play the discussion that if you have a religious exemption, you will not be able to be forward-facing with anyone, any healthcare provider or patient either. So that creates a very narrow window where basically these folks could do remote work only, as long as they would never come into contact with staff or patients. So obviously that's a very narrow alley. We have talked internally within the U of R, and our council believes that there probably is no justification to have an allowance for medical exempted patients to be able to be forward facing and religious exempted patients to not be forward facing. So that creates a degree of discomfort and uncertainty from a labor practices standpoint. So that whole thing is still very much in discussion at this moment. And so because of that, while we have told employees within the U of R system that they can begin submitting their religious exemptions, we really haven't been doing a whole lot of review and approval just because we're unsure what the guidance or requirements are going to be. But at this moment, sans an exemption, which should be a fairly narrow group, be my interpretation. Anyone who is not vaccinated, has not received the first dose by midnight on September 26th, would either be terminated with cause, and if they are a licensed provider or healthcare worker, they would have to be reported to OPMC for being terminated, in their employment being terminated, or they can be it'd be considered a voluntary resignation, which the employee does not have to sign anything or agree to it. They could just be voluntarily resigned because there is work for them, but they're choosing not to comply with the requirements of that work. It still seems the state would want or was requiring that those employees be reported to OPMC as well. So that is still a subject of clarification that we are working towards at the moment. So a lot, when I tell you that this vaccine mandate stuff kind of changes or evolves day to day, that is not an over exaggeration. I know I said that last week. It is really no different at this moment. So there is another call between Haney's Department of Health and the governor's office tomorrow morning to discuss this in more detail. So hopefully there'll be more clarification. To Elizabeth Murray's question, it varies a little bit by institution, but across the board, I think for those who are absolutely refusing, we'd be looking to lose somewhere between 6 and 10% of the workforce. If we look at worst case scenario of everyone who is currently not vaccinated, refusing to comply, you could look at losing as much as 20% of the workforce. So it's a fairly sizable effect and would have fairly significant ripples as far as healthcare delivery, to be certain. Along with that, we talked about the state mandate. There is the federal mandate for nursing homes. The report that I've heard is that there have been filings for closures of nursing homes in New York State. I do not believe it's local. I've not heard of any formal filings for closure at this moment. I have heard of nursing homes closing floors or units and reducing bed capacity. I do know that there have been some delays in discharges from hospitals because of lack of nursing home beds. So that is causing, back to where we were before, some delays in discharges and decrease in available bed census at a time where we may need it most. So we're starting to see those effects. We have heard of at least one nursing home group in Rochester that has publicly stated that they are going to refuse to comply with the state and federal mandate and kind of dare those parties to see what they'll do to them. That's the only group, I've only heard of one group that has taken that stance as of yet. But as the time gets closer, we'll see what unfolds with that. So I wouldn't say that the nursing home has become a widespread problem at this moment, but it is certainly a mounting concern and one that we're kind of keeping an eye on for sure. I did see another chat pop up. Overwhelming will remain because they are vaccinated. That is our anticipation. We do think that there is a good number of employees who are likely to kind of play chicken and push this to the 11th hour and then probably want to get vaccinated late on the 26th once they've exhausted all hopes that this mandate will be softened or reversed. That's the expectation. I can say even from the hospital administration standpoint, we have received resignations that are effective on the 27th. So people are kind of holding hope that there'll be some change. We have had a few that are, resigning immediately. Some folks have just decided they're going to pursue careers outside of medicine. A few are going to try to test the fates and go out of the state. Although I think we're now at 25 states that have a mandate with more being added. But, the anticipation is there will likely be some of the southern and Midwestern states that will likely not go to a firm mandate. But then there are other states like Illinois that has a mandate, but does have a testing alternative in their mandate. So, there are shades of gray throughout all of this. So a lot more to come. I suspect every day is going to be a little bit different than the day before. I will say September 13th is somewhat of a magic day at the moment because staff who can resign with 2 weeks' notice without any penalty or deleterious action against their licensure theoretically may resign on or before the 13th. Because conceptually, anybody could come in today and say they want to resign if their contract says they only have to give 2 weeks' notice. And they don't have to give us a reason that they're resigning. It's completely their choice. So the general feeling is we probably would not have reason to report those folks. So does that mean that we're going to see a rash of resignations in the next 5 days? It somewhat remains unclear at this moment. Obviously, we're trying to get as much clarity as possible from the state and the governor's office. But I think there's a lot of waffling. We've got a governor who needs to be elected / reelected in 1 year's time. We've got a Department of Health that's getting completely overhauled as we speak. So, there's a lot of moving pieces to this, and sooner or later somebody has to draw a line in the sand. And I don't know when that day is going to come because, believe it or not, they don't feed me to know that. Nor do they tell me anything. So that's where we stand from the mandate standpoint, causing a lot of consternation, fear, and concern amongst employees, amongst administrators. But it's really just an unknown at the moment for right now. I think that is all I wanted to cover. LJ, do you have anything you want to cover? Any additionals?
I actually do not, Chad, just if there are questions that have come up from folks, there's not anything else that is really changed in terms of back to school guidance or anything at this point. Yeah.
Okay.
Chad, you were going to talk about the pharmacy parole that just went out?
Yes. So thank you. So the AHP pharmacy team did just put out a pharmacy pearl about ivermectin use. This has caught fire again and become a big thing. I think their pearl lays it out very nicely. The data for this is very sketchy, I guess is the best word I can say for it. But it is certainly getting touted in certain circles. I will say political affiliations again play a role in this as to how much folks believe in it. Even hydroxychloroquine seems to be coming up again and catching fire. So, I think people are looking for avenues that are for those who are very convinced against the vaccine. I think they're looking for avenues to try to protect themselves against the surge of COVID, but potentially pursuing at best what are risky considerations and at worst, which may be downright harmful. So I think the Pearl summed it up very nicely. So that went out yesterday, I believe, for folks to take a look at if you haven't already. Hearing from someone students received COVID do not need, they've had COVID, do not need a return to play clearance if they're under 11 years old. It's not active. I'll let the team pediatrician take that one.
Sorry, I was just reading that myself and trying to unmute. So I am going to see if I can share. Give me a second. Keep talking if you have something to say, Chad. I'm going to see if I can share that.
You need me to bring up
algorithm.
that logarithm, that
Oh,
algorithm?
Yes, that
Okay.
would be lovely.
Hold on.
Because there were a variety of iterations that happened with that return to play algorithm over the course of last spring, well, winter and spring. And that was because the American Academy of Pediatrics continued to update their guidance on that based on experience across the country. So let me just run through this. I apologize for those of you who've seen it a lot or who it doesn't apply to. Renee, if you can enlarge it, you can enlarge it a little bit more. That helps for other people. So essentially, this is for any patients who have had COVID-19. The notion is that there is some potential risk for myocarditis. In reality, there have been very, very few patients that we've actually seen who've had myocarditis, but the recommendations remain in effect. So every patient with COVID-19 is to have an evaluation by their PCP. This is your pediatric, adolescent, college students. It would be after they've been released from isolation, not before. Now, the thing that's different is there is a difference in age in terms of how this applies. So if you have a patient who had mild or no symptoms, who has a PCP evaluation, or even if they've had moderate symptoms and have a PCP evaluation and they really don't have any significant systemic symptoms, they don't meet the higher risk category for symptoms, and they're less than 12. That's the big thing that changed. If they're less than 12 years of age, they can go back into their regular activity. They don't require an observed return to play. The difference would be if you have a child who's engaged in a high competitive sport situation. So every child should have some evaluation following it. The AAP's guidance suggested that for the younger children who fall in low risk category because of age and low risk with mild or no symptoms, that could be done through a telemedicine visit potentially, that it might not require an in-person visit, because that's where a lot of people were getting stuck. I hope that answers the person's question there, but there is nothing about this does not apply to return to playground activity. This does not apply in terms of return to a child participating in a school PE. What it does apply to is a child who's engaging in, a higher intensity sport. So Susie's question about how does somebody do a cardiac assessment on a virtual visit, I totally agree with that. I think that some people are at least trying to do a historical assessment for the younger kids. I still think you should be trying to get them in, have them assessed and review, but at a minimum, they should at least be screened for any symptoms post-COVID and assessed if they really had moderate or more significant symptoms for COVID. If they're severe, they've already been, that's really your MISC kids, and they should already be engaged with cardiology. So I hope that helps. This is posted on the GCH website. This is posted on on our AHP website as well for people to walk through. It's still a little bit complicated. The notion is that risk does exist. Certainly if you have a child who has pre-existing cardiac conditions where they're followed frequently by a cardiology specialist, those kids do fall in a wholly different category. And those are ones you absolutely would need to see and would need to have them follow up with cardiology. The cardiology teams have remained very good about being available to assess these kids quickly for the ones that have been referred.
There's one more question in there, LJ. How does one do a cardiac exam on a virtual visit?
That's what I was just saying to them.
Oh, sorry.
Yeah, no, it's okay. The best thing is to bring that child in, but we have heard from some of you that parents have refused to bring kids in for these follow-up evaluations. And so I think that at a minimum, you need to do some assessment through a telemedicine visit. And ideally you're bringing them in so you can actually take a listen to their heart and check their blood pressure.
And I just want to clarify, because a couple of folks direct messaged me. So, and I may have misspoken. So as far as the vaccine mandate, it does not yet apply to private practices. So only hospital settings or congregate care settings or nursing homes. Although there has been discussion that they anticipate it will extend, and also it does apply to home care as well. I should have thrown that in. So while they have made suggestions that it will be extended to all healthcare providers, it as of yet does not apply to private practices. And I have the article that or the public health article that they're using to enforce this mandate would not have domain over a private practice. So I don't know how they're going to make that leap without legislative action at this moment. So just to clarify, that mandate update was really just about hospitals, nursing homes, or home care areas. Renee, anything else that we missed or?
Nope, nothing that I know you guys were going to cover, but I just have 3 items really quickly. If that's okay. We'll include links to everything I'm about to talk about in today's email. Want to make sure folks saw the request from New York State DOH to respond to a COVID-19 vaccine booster survey, and we'll be including the link to that survey. Even providers who are not currently participating in COVID-19 vaccine administration would be welcome to participate in the booster campaign, and they're asking providers to complete a short survey to indicate their willingness to participate in that. So whether or not you want to participate, we ask that you do please complete that survey so DOH has a handle on capacity for this important campaign. There was also a recent update from DOH regarding direct orders for Janssen, for J&J vaccine, which is reopened yesterday, September 7th. And we'll have all the details on that in a link on the web on the email today. And then finally, CDC has scheduled for tomorrow a webinar for providers. It's part of their clinician outreach and communication webinar series. And this is going to be, presenters are going to provide updates on the Advisory Committee on Immunization Practices, recommendations for the 2021-2022 influenza vaccination season, and guidance on co-administration of influenza and COVID-19 vaccines. That's taking place tomorrow between 2 to 3 p.m. via Zoom, and we'll have that information in the email as well. That's it for me.
Perfect. So I think we're caught up with the chat room. So unless anybody has any other questions or anybody has last minute thoughts that they want to share? Preferably about COVID, but willing to entertain just about anything. All right, I'm not seeing any going off mute or any excitement in the chat room. So we will continue with weekly for now. Like I said, I anticipate there may be some developments in the mandate discussion in the next week. So that will definitely be apropos, and then we'll be within a week of the potential booster doses starting for the general population. So next week, there should be a reasonable docket of things to begin talking about. And all the local kids will be back in school by that point. So I'm sure there'll be much fun and excitement coming out of that. So we'll just have a host of fun topics to come up in the next 7 days. So enjoy while you can. Hopefully you have a lovely rest of the week, and we will reconvene next Wednesday. Thanks, everybody.
Take care, everybody.
Take care.